Okay, Pregnancy at Risk, Chapter 17, Part B. Placenta praevia. This is a condition in which the placenta is implanted close to or covers the cervical os. And so that is when the placenta is actually sitting on that part which is supposed to dilate. You can see the problem there. The exact cause is unknown, and conditions that increase the risk could be a history of elective abortions. If you think about it, usually the placenta is supposed to be up on top. However, if there's scar tissue up there, the placenta will kind of pick and choose where it wants to go, and it's not going to implant up on that scar tissue as well as it might some other place. Multiparity, advanced maternal age, older than 35 years old, previous cesarean birth or any kind of uterine incisions, maternal smoking, and then prior placenta praevia. So it's classified according to the degree in which the placenta covers the cervix. So you can have total placenta praevia, which rarely ever resolves. You can have partial placenta praevia, which as the baby kind of grows, that placenta will pull up over the cervical os and it won't be quite so covering. With this, you might be able to go ahead and have a natural vaginal delivery, or a marginal placenta praevia is the same time. Part of it might be covering that cervical os, and as the baby grows, it might move up on the wall where it would be okay to go ahead and have a vaginal delivery. Clinical manifestations include painless bright red bleeding. The first bleeding episode usually occurs somewhere between 27 and 32 weeks gestation. Additional examination of the cervix is going to be completely deferred until placenta praevia has been excluded, so they would be on pelvic rest. You wouldn't want anything going up into the woman's vagina or touching her cervix. A diagnostic test of choice is going to be a transvaginal ultrasound, so this is the one exception of what would actually go into the vagina and check to see whether or not she has placenta praevia. Usually the first bleeding episode does not harm the fetus. It's not enough bleeding to actually harm the fetus. It will usually stop on its own. Total placenta praevia is associated with atypical fetal presentation, so usually they're side-lying, not head down, not transverse. The treatment, if massive bleeding occurs, is going to be immediate cesarean delivery. It's a life-saving measure for the woman and her fetus. The Claiborne-Bate test is to test and see if the fetus's blood has been mixed in with the maternal circulation, and if so, that would show that there is some kind of hemorrhaging taking place. Anti-D immunoglobulin ROGAM, if the mother is Rh negative, then we will be giving that. Serial non-stress test, just to check on the baby, make sure that the baby is doing okay, is not under any kind of stress. And then a cesarean delivery is necessary in all cases of total placenta praevia. You will not labor a woman who has total placenta praevia. Think about the cervix dilating with that placenta being right on top of it. It's going to break vessels and she will bleed out. Nursing care requires careful nursing observation, IV access at all times, because you have to think we might be going for an emergency cesarean at any time. We're going to be assessing for signs of shock. We're going to be listening to that fetal heart rate at least every 4 hours, if not more frequently. Oftentimes they will be hooked up to the monitor. Then postpartum care, that's going to be pretty much normal. You're just going to assess for signs of infection and hemorrhage. Placenta praevia. Okay, here you can see the low-lying placenta. Here's your cervical os, and this is the part that is going to dilate in a phase. So you can see with a low-lying placenta, you might have a chance of it going up the wall. Partial placenta, it's covering a little bit of it. So again, maybe as she grows, the placenta will move up the wall. And then a total placenta praevia, you can see where if she were to start dilating, those blood vessels would erupt and start bleeding out, and the baby would suffer from that, and the mother would suffer as well. So placenta abruptio, this is premature separation of a normal implanted placenta. So what is happening here is the placenta is up high, however, it's starting to peel off of the wall of the uterus early. The cause is usually unknown, but there are some risk factors that can go along with it. Conditions characterized by elevated blood pressure, preeclampsia, or pre-existing chronic hypertension, advanced maternal age greater than 35. You can see where after so long these women who are over 35 hear that they're at risk for everything and it gets a little bit too much. Multiparity, a history of a cesarean delivery, trauma, any kind of motor vehicle accidents, domestic violence, anything like that might bring a woman in with placenta abruption. Cigarette smoking can cause this, alcohol consumption, cocaine use is a big one, and then premature rupture of membranes. Classified in several ways. The bleeding is either concealed, which is hidden, so you have the placenta, and rather than one side of it just peeling off and folding back, it's underneath and it's concealed and you don't see it. So the middle part of that portion might peel off the wall, but it's still bleeding back there, but we're not seeing anything. We don't have any evidence of it. Degree of abruptio is either partial or complete, so part of the placenta might fall off the wall, or it can completely detach itself. The maternal complications with this include hemorrhagic shock, DIC, uterine rupture, renal failure, and death. So very severe. Severity and type of fetal complications are related to the degree of the placenta separation and the maturity of the fetus. And so some of the risk factors or complications that can take place with the fetus is hypoxia, anemia, growth retardation, and even fetal death. So, clinical manifestations. Preliminary diagnosis is based on signs and symptoms of the patient. Pain is a sudden onset and it's constant. A lot of times it will be dark red bleeding and a board-like abdomen. They will do an ultrasound and usually they're able to tell from this. Treatment is vaginal delivery is still preferred over cesarean birth for small abruptions. If, however, it was a complete abruption, they might have to go ahead and get that baby out quickly so that the baby doesn't have fetal demise. Nursing care requires careful monitoring, assessing for signs of shock, continuous electrofetal monitoring, being prepared for an emergency C-section at any time, and then after delivery, it's going to require close monitoring for postpartum hemorrhage, as well as continuing to observe for DIC. Okay, nursing process for the woman with a bleeding disorder. We're going to skip these two and we'll go over that in class more. We're going to jump right into hypertensive disorders. You do have a case study that will go with that, so be sure to look at that and fill that in. Okay, so hypertensive disorders in pregnancy. It's the second leading cause of maternity, morbidity, and mortality. And morbidity is the incidence of the disease, and mortality is the frequency of deaths. So second leading cause of maternal morbidity and mortality. It's not only dangerous for the pregnant woman, but it's also significantly increases the risk for the fetus. And there's 4 basic categories here. You have gestational hypertension, preeclampsia and eclampsia, chronic hypertension, and then preeclampsia superimposed on chronic hypertension. And we're going to break each of these down and go into details on it. So first, gestational hypertension. This is the current term used to describe elevated blood pressure, which is going to be 140/90, greater than or equal to 140/90, that develops for the first time during pregnancy. So this is a woman who comes in, she's never had hypertension before, she's pregnant now, and she's all of a sudden got a high blood pressure, 140/90. It can be transient or chronic. Okay, preeclampsia and eclampsia. Preeclampsia is a serious condition of pregnancy in which the blood pressure rises to 140/90 or higher and is accompanied by proteinuria. So now you're going to start seeing why it's so important that we test the woman's urine every time she comes in. This is preeclampsia. Eclampsia means she has high blood pressure, 140/90, plus protein in the urine. Okay, so preeclampsia versus eclampsia. And maybe you're thinking, what is the difference there? Preeclampsia is before the woman ever has a seizure. After she has a seizure, or if she does have a seizure, it's going to be called eclampsia. So there's the difference in there. Okay, so it may develop into eclampsia, and that's the presence of seizure activity or coma in a woman with preeclampsia. Okay, so eclampsia after she has a seizure. The exposure to trophoblastic tissue appears to be one of the triggering factors that can cause a woman to go preeclamptic. Okay, so we just talked about molar pregnancy. It can cause women to go into preeclampsia. There are no diagnostic tests available to show this. African American women are more likely to develop preeclampsia and are 2 to 3 times more likely to die of preeclampsia or eclampsia than white women. Primary problem underlying the development of preeclampsia is generalized vasospasm. And so what that's talking about is the persistent contraction of a vessel reducing its blood flow, causing hypertension. Edema is significant if it's non-dependent or if it involves the hands and feet. So non-dependent means it's happening in the face, hands are okay, feet means it's dependent edema, that gravity is causing that edema. It's categorized as mild or severe, and then seizures are usually tonic-clonic in nature and only rarely progress to static epilepticus. She has seizures, you know what I'm trying to say. Okay, HELP syndrome. This is a severe form of preeclampsia and eclampsia, acronym for hemolysis, elevated liver enzymes, and low platelets. So this is something that occurs very rarely, but can occur in a very severe form of eclampsia, preeclampsia. Okay, treatment for it, primary goals of therapy are to deliver a healthy baby and restore the woman to a healthy state. So there is nothing that is going to treat eclampsia except for delivery of that baby. Okay, we are also going to have to time that delivery very carefully. We don't want the mother to go into a worse state, to have seizures, anything like that, but at the same time we're also worried about that baby being mature. We're going to prevent maternal seizures. We might have to administer mag sulfate, and what that does is it's going to raise the seizure threshold, make it where she's not so likely to have a seizure. However, it also will cause your reflexes to go down a little bit. So we're going to monitor the reflexes very carefully, and it can depress her respiratory rate. So we've got to be monitoring her respiratory rate very carefully as well. Monitor the reflexes, monitor the respiratory rate, and think about that as the diaphragm is also somewhat of a reflex as well. So it will depress those things. However, calcium gluconate is going to be the antidote to mag sulfate. So we'll make sure that we keep that close by if we are administering mag sulfate. Therapeutic level is going to be 4 to 8. Right? So, nursing care. Woman and fetus require frequent monitoring. We're going to be watching them very, very carefully. It's important to osculate the lungs every 2 hours, again, especially when you're giving her mag. It can depress that. Weigh the woman daily. Make sure that she's not retaining any kind of fluid. Report headache, visual changes, epigastric pain. These are very significant, and if she does complain of these things, we are thinking in the back of our mind that a seizure is not far off. So those are very important things to monitor and watch for, and let her know that she needs to make us aware if she starts having any kind of headache, visual changes, or epigastric pain. Think with headache, increased ICP. Visual changes, same thing. So we're going to assess the deep tendon reflexes, determine if clonus is present. We're going to implement seizure precautions, so think what that means. O2, oxygen at the bedside. Think of those things. Patting the side rails and then having suction in the room as well. Okay, the woman should remain on bed rest. Adequate nutrition, psychosocial needs. If she's on bed rest, think about that as well. She might get bored. She wants to go and do and be elsewhere, but she has to stay there for the baby. We will be doing non-stress tests on the child, the baby, about 2 times a week to make sure that the fetus is doing okay and isn't under any kind of stress. Postpartum care. If max sulfate was not administered, the woman will be transferred to a postpartum unit and cared for as any other client. If used, however, if max sulfate was used, she's going to receive care in the labor and delivery unit or at a high-risk antepartum unit for 24 to 48 hours after delivery. And we are going to do MAG recovery on her, which means, what does that mean? We're going to restrict her activity, we're going to restrict visitors, and keep the lights dim, no flashing lights. And these are patients who we do not do any kind of pupil checks on. We're not going to flash lights in their eyes. That could cause another seizure, so we'll avoid that. Chronic hypertension and preeclampsia is superimposed on chronic hypertension. Okay, the woman comes in, she already has chronic hypertension. However, now she has developed preeclampsia. So chronic hypertension is blood pressure that is present before the woman becomes pregnant. Clinical manifestations of this: blood pressure remains elevated after pregnancy and the woman has chronic hypertension. Superimposed preeclampsia is when she experiences protein in her urine. Okay, treatment and nursing care. Prenatal visits occur more frequently. Fetal surveillance is an area of intense focus. Aldomed, methodopa, that is the hypertensive of choice for maintenance therapy. We're gonna, okay, that's all with hypertension. So let me check. I think we got everything there. Okay, moving on. Multiple gestation. Okay, multiple babies. This is when a woman is carrying more than one fetus. Twins. You can have twin-to-twin transfusion syndrome, TTTS. Multifetal pregnancy is at risk. You can have the mother who has hyperemesis gravidum. Again, we just talked about that. She is more at risk for it with multiple gestations. Pyelonephritis, preterm labor, placenta praevia, preeclampsia, and eclampsia. For the twins, they could be conjoined. They could experience growth restriction. Sometimes one twin will grow bigger and one twin will have the growth restriction, or they can be born prematurely. During the postpartum period, the woman is at risk for postpartum hemorrhage. Anytime she has multiple gestations, she is at higher risk for postpartum hemorrhage. It also increases fetal nutrient demands, and the mother may become anemic. Clinical manifestations: the uterus is often larger than what she should be measuring for dates. Increased treatment: we're going to increase emphasis on the woman's diet, multivitamin and iron supplements, and rest. And the practitioner must choose or recommend a mode of delivery. Will she go ahead and try and have a vaginal delivery for both, or will he set up a C-section? And often it's determined by the placing of the fetuses, or if she's had a C-section in the past. The nursing care: we're going to assist the physician to perform assessments. We're going to instruct the woman regarding symptoms of preterm labor. She's going to perform fetal movement counts daily after 32 weeks gestation. We're going to encourage the woman to get adequate rest and maintain a well-balanced diet. Okay, so blood incompatibilities. Okay, so this is incompatibilities between the mother's blood and the fetus's blood, and it can cause huge problems for the fetus. Not the mother, but the fetus. So there's 2 types of blood incompatibilities. In Rh incompatibility, we have talked about the mother is Rh negative, the baby is Rh positive. The mother's antibodies start attacking that baby's Rh positive blood, and it sees it as an enemy, starts tearing it down, breaking it down, and can cause the baby to become anemic. ABO compatibility, same thing to a lesser degree though. So RH incompatibility is RHD factor, so a factor in the blood is the RHD. The mother is RH negative, the baby is RH positive. This causes an isoimmunization and the fetus develops hemolytic anemia. The cure is RhoGAM, a shot given to the mother. Clinical manifestations: the woman will have no symptoms at all, however the fetus may be severely affected. Again, treatment will be the RhoGAM shot. Criteria for giving the RhoGAM are as follows. The woman must be RH negative and the woman must not have any antibodies, i.e. she has not had RhoGAM in the past, she's never built up or become sensitized to these. And the infant must be RH positive. The fetus's blood type is not checked after abortion, so a lot of times, depending on if the mother is RH negative at all, she had an abortion, we'll go ahead and give her a shot of RhoGAM. Direct Coombs Test is a test for antibodies, and it's performed on cord blood at delivery, and it must be weakly reactive or negative. Okay, so ABO compatibility. It's another cause of hemolytic disease of the newborn. Most frequently arises when the woman's blood is type O. So if the mother isn't type O, we're really not concerned about this. And the fetus's blood is AB, A, or B. A or B or AB. And again, you can often look at the father's blood, look at the mother's blood, and even see if this is going to be a problem that they have to worry about. It's much less of a severe form of hemolytic disease than the RH incompatibility, and the fetus rarely requires any kind of blood transfusion. Okay, that takes care of it for today.